Then we're coming to peripheral nervous system. Peripheral nervous system, as you know, it is sensory and motor. We have large fibers which are myelinated. Myelin is nothing but a sheet covering the axon. Myelinated, their large fibers are mostly they're myelinated. They transmit the impulse faster than the small fibers. These large fibers are related to your joint and position sense, and small fibers are related to your pain, temperature, and your autonomic nervous system. They are unmyelinated small nervous fibers. The conduction is a little slower compared to the large fibers. That these differentiating points you should understand. And in peripheral nervous system, we have sensory and motor also. In motor, the motor system begins from the anterior horn cell. Actually, the motor system begins from the cortex, the bed cell, BETZ, bed cell. Bed cell, then the motor cortex, the motor fibers, the corona radiata, they come through the internal capsule and come down, and they come into the, via the brain stem, they come down, receiving fibers from the cerebellum. They come down into the spinal cord and decussate wherever they are bound to. And from the anterior horn cell, the peripheral nerves begin actually. That is the point of beginning of the lower motor, what we call it, the lower motor. From the anterior horn cell, the lower motor system will develop. So we have got to differentiate, identify upper motor, lower motor because of this reason. So clinically, you can separate out in a given patient, history-wise and examination, you can separate out, is it upper motor neuron lesion or it's lower motor neuron lesion. It's very easy. And coming to autonomic nervous system literally regulates every function of the body, every function, like your cardiovascular system, because it is connected to your heart cardiac function, sympathetic and parasympathetic nervous system, and your respiratory function, your gastrointestinal movement. Yesterday we were listening to Dr. Kishore's lecture, and your endocrine gland, all your, even pancreas, even your thyroid secretion depends on your autonomic nervous system. So that's a very, very important. And autonomic nervous system examination, autonomic nervous system related tests are separate, and you have to any elderly person coming to with unexplained symptoms of not able to walk properly and falling down frequently, this could be a dysautonomy, or passing urine in urinary incontinence or fecal incontinence. You can think of the autonomic nervous related disorder, especially in older people who have diabetes. So autonomic nervous system is a topic you can read. You can read this autonomic nervous system. It is divided into sympathetic and parasympathetic nervous system. And motor system, as I told you, it starts from the bed cells. From the motor cortex, it comes down and the pyramidal tract, because the shape is like pyramid. By the time it comes down from the internal capsule, come down, it takes a triangular pyramidal cell. That's why we call it as a pyramidal tract. Pyramidal tract is nothing but cortico-spinal tract. It passes through internal capsule. So again, apart from all these things, we also have certain special areas in the brain called extrapyramidal system. Extrapyramidal system, basically, it is a basal ganglia. You must have. Can you type what are the parts of the basal ganglia? Students, please type the parts of basal ganglia. What are the putamen is right answer. Right, globus pallidus, substantia nigra, caudate nucleus. Okay, these are called a special group of nuclei called basal ganglia. They have a very beautiful function to do, but they also depend on the cortical information. Nothing can happen without the cortex, the central government. For everything, whatever we do, the cortical support, cortical permission, the central government permission is needed. So whatever these substances, the subthalamic nuclei and all, they have independent function, but they should receive the information from the cortex, without which they cannot work fully independently. So the basal, this is called extrapyramidal system. They control the muscle tone. That's why in Parkinson's disease, which is basal ganglia, substantia nigra is involved. We'll talk about Parkinson's disease when we come to that topic. Parkinson's disease, you get rigidity. Patients will have cogwheel and what else? Cogwheel and lead pipe, clasp knife, lead pipe, cogwheel rigidity. The rigidity is related to your muscle tone. When your basal ganglion is affected, like in Parkinson's, the patient will have rigidity. And the basal ganglia controls not only muscle tone, but also your body posture. That's why a Parkinson's patient will have the stooping posture. Your posture is maintained by your basal ganglion. You're walking like this, but ultimately you're nobody. Your brain, your basal ganglion is intact. That's why you're able to walk nicely. Then initiation of the movement. Of course, the continuation of the movement will be done by the cortex, motor system. But initiation of the movement, about to start walking, the few seconds before you walk, that is controlled by your basal ganglia. That's why people with Parkinson's disease, they also have involuntary movement. So it controls not only muscle tone, but also the movements of the body. Coming to cerebellum, that is a small brain, very important. Actually, cerebellum has many neurons than the entire brain. Though it looks small, it is about 1/5 of the size of the cerebrum, which is sitting in the posterior cranial fossa. It has a maximum number of neurons more than your cerebrum. So it has a lot of, it is folded into many, it is like as if I am folding paper many times like that, it is folded. That's why the number of neurons are many in cerebellum. So cerebellum mainly controls the coordination movement, coordination of everything. Coordination, even when I'm writing also, my writing also, though my muscles are intact, though my motor system is intact, my pyramidal tract is intact, my cortex is intact. But if my cerebellum has something wrong, my writing, coordination of my writing goes haywire. So coordination of anything, even walking, even speech. When speech center is normal, everything is normal. If there is a problem in the cerebellum, you have a cerebellar speech dysarthria, cerebellar dysarthria. So coordination of speech, coordination of swallowing, coordination of walking, coordination of movement is controlled by your cerebellum. Planning. So planning also is controlled by cerebellum. Learning the skilled movement, the finer movement, the skilled movement also is a function of cerebellum. Of course, for that, it has to take the help of thalamus and the cortex and other connections. So I said nothing will work independently. Everything is in a coordinated, cooperated way. They work in all these parts of the brain. And even the smoothness of the eye movements. Eye movements are controlled by your third, fourth, sixth nerve. There is no doubt about it. Your third, fourth, sixth nerve movement. When they are damaged, you have a conjugate eye palsy and others. But in spite of those third, fourth, sixth nerves being intact, if there is a cerebellar function, the smoothness of the extraocular movements will be disturbed. So that is the function of cerebellum. Even coordination of this also will have some connections from the cerebellum. Similarly, as I said, speech and vision also. Though vision is controlled by your occipital lobe, the cerebellum also has some connection. The vision also is disturbed in cerebellar lesions. So coming down from cerebellum to spinal cord, of course, spinal cord, you have all the tracts that I mentioned, and they have roots, they're emerging roots, anterior root and posterior root. The diseases, the spinal cord diseases, one interesting thing is the spinal cord diseases can be diseases in the spinal cord itself or diseases outside the spinal cord causing spinal cord diseases. Like, for example, meninges. The meninges are covering entire spinal cord. If there is a problem with the meninges, spinal cord symptoms signs will come. Or if there is a problem in the vertebral body, for example, osteomyelitis, port spine, tuberculosis spine, the disease is actually in the bone, but they compress the spinal cord and cause spinal cord myelopathy and other things, paraplegia and others. So you should be able to identify where is the disease. Is it spinal cord per se or outside? So in the spinal cord also, the level of lesion is very important. Somebody will have exactly a band-like sensation here. You can differentiate if you go on touching the patient, one particular area there will be complete anesthesia from one line onward, depending on the dermatome, depending on the nerve supply. They'll have normal temperature and pain and touch sensations. So that means that particular segment of the spinal cord, there is a problem there, like your transverse myelitis. So neurology is a very beautiful. Really, if you really take in special interest in neurology, read for 2, 3, 4 times, you can master. And in an examination, invariably, in your final examination, the long case is kept as a neurology. Most probably a stroke patient we keep. So you should be well versed with stroke, all those syndromes, all those brain supply, blood supply, the circle of Willis, or how these artery supply, what are the functions, which artery lesion will cause which problem. So patient will come with what. So this is a mathematical calculations like thing you should know all these things. And again, as I said, spinal cord you have compressive and non-compressive myelopathy. So I think we have 5 more minutes. This is briefly about brain. You must have read all these points in your anatomy and physiology, but because we are beginning the neurology classes from tomorrow, I thought this is important for you to brush up your quick CNS related issues. So tomorrow onwards, we'll take up one by one diseases, important diseases that can be asked in the examination, and finish off CNS. So if you have any questions, quickly 1 or 2 questions, we'll take up. Huh? Yes. Thanks for reminding that. I'll show you one video. Can I? Okay. Just a second. Okay. We'll close here. Thank you and good night. Take care. Bye-bye.
What are watershed areas in brain?
Yeah, who's asking that name? So yeah, watershed areas, we will talk when we come to cerebral vascular diseases clearly. Watershed area is nothing but there are arterial territories, you know, middle artery, cerebral, middle cerebral artery, anterocerebral, ACA, MCA, PCA, anterocerebral, middle cerebral, postcerebral. The areas which are supplied by these specific areas, specific arteries have different zones. In between these zones, there is a small area of watershed. What is called watershed zone. Sometimes the watershed infarcts also are possible because of some hypotension or dehydration. So in spite of there no being any block or any thrombus in the arteries, you can have infarct in these watershed areas. Watershed area is nothing but the area between the main arterial supply zone territory. That's called watershed area. We'll talk about that in detail when we come to cerebral vascular disease. Okay. Bye-bye. See you.